Good morning, ladies and gentlemen. Professor Savas, Professor Olga, thank you very much for inviting me again to this wonderful meeting of Athens Elbow course. I believe Professor Adam Watts had a nice, wonderful talk about elbow dislocation. His clear message on management and pathomechanism. Hopefully you have a better understanding of simple elbow dislocation. Now today, I'd like to share a little bit of different idea on simple elbow dislocation, a bit unusual, but not uncommon pathology you may encounter in your practice. This is osteochondral lesion in simple elbow dislocation. As you know, simple elbow dislocation and complex elbow dislocation, you see the associated fracture, such as coronoid, radial head, Montegia, then it is classified as a complex elbow dislocation, as you can see here. And simple elbow dislocation is basically soft tissue injuries, as you can see. Right, everybody knows how to deal with the simple elbow dislocation, closed reduction, and long arm splint for 1 week or 2 weeks, depending on the injury. So if it is stable throughout range of motion, we can allow early range of motion exercise. However, if it is unstable, I mean any subluxation at elbow 60 degrees or more flexion, you may consider MRI or examination under anesthesia. To check the lateral stability, you may pronate and apply varus force. For medial collateral ligament complex, you may supinate the forearm and apply valgus force. So I'd like to introduce these two interesting articles which I read. Long-term outcome of non-surgical treatment in simple elbow dislocation. Dr. Josephson and Dr. Anakwi, they reported somewhat different results. Dr. Josephson had a very long-term result of 24 years, no recurrent dislocation or no instability. However, Dr. Anakwi, his patient of 110, follow-up of 88 months, actually 8% has objective elbow instability, and over 50%, over half, more than half of his patients had stiffness or pain. So why we have these two different results after simple elbow dislocation? So the essential fundamental question here I would like to raise to you is a simple elbow dislocation really simple? What is your idea? So I don't know how many of you order MRI for simple elbow dislocation, but this in my country, MRI is very, very common. So this is one patient who was referred to me with his own MRI. 60-year-old male had an elbow dislocation after trivial fall. He's a very active sportsman, but as you can see here, after closed reduction, you can see the diffuse extensive soft tissue injuries around the elbow joint. Okay, so we have done a stress test, and you can see the varus opening of radiocapitellar joint, and pivot shift was rather positive. So this is not very unstable joint, but the patient would like to return to sports and daily activity quickly, so we attempted arthroscopic collateral ligament repair. So when we put the scope in, this is an ulnohumeral articulation. You can see the wide opening of olecranon and trochlea, which means lateral part of the collateral ligament was completely torn. But one thing interesting is here. As you can see, the capitellum and radial head, there's a significant cartilage defect you can see. And also posterolateral part, the capsule and the collateral ligament complex was completely stripped off from the bone, and you can see the bare area, bare spot. This is almost the same as like the heel sox lesion in the shoulder joint. So what does that mean? This means, as you can see here in a cadaveric observation, your radiocapitellar joint, as you supinate and extend, anterior part of radial head and capitellar posterior part is engaging. This is exactly what I proposed years ago. I know I was very proud that you guys talked about this ostium collateral lesion many years ago. So this is basically very similar to bony Bankart and heel sox lesion of the shoulder. So what we have done was putting an anchor screw percutaneous and then attempted arthroscopic LUCL repair. So that for this conjural defect, we have done a micro fracture, and the patient had a little bit of HO. Otherwise, the patient was very happy with the good functional range of motion. So according to our analysis, there's two different pattern of OCD lesion you can find in OJSM last year. If you have valgus external rotation force, where's the contact point? Contact point is a posterolateral capitellum with the radial head anterior part, and this is going to make a shear injury, shear force, because the pivot axis is applied at this point. And then eventually medial olecranon fossa is going to be impinged. The other thing, varus internal rotation injury, as you can see in this illustration, when you apply varus internal rotation, the first contact point is posterior trochlea and the coronoid anteromedial. This is why we have anteromedial facet fracture of a coronoid. And then eventually lateral olecranon fossa is going to be contact point. So let's have a look at the example. This is a typical posterior elbow dislocation. And you can see in the MRI, posterolateral part of capitellum was injured. This was rather a fracture, and the anterior part of radial head is contused, and medial olecranon fossa is impinged with the olecranon process. So this is a very typical pattern of valgus external rotation injury. So we took out the loose body from the joint and then repaired the lateral collateral ligament. This is another interesting case of mine. 63-year-old male had an elbow dislocation, and the surgeon who saw this patient first did a diagnosis of simple elbow dislocation. Okay, but as you can see here in the plain X-rays, it's not really simple because you can see a small, freckles of the bones. But the interesting thing is, if you take this MRI, CT scan, there's a lot of small fragment with the clear subluxation of ulnar humeral joint. So coronoid anteromedial has been very much comminuted, and the joint is subluxed. So definitely the joint is unstable when we apply the varus internal rotation. This is a typical example of varus posterior medial instability. When we put the scope in, can you see this trochlear fracture here? This trochlear fracture is very interesting because there's no injury on the lateral part, radiocapitellar joint, only the small cartilage fragments all around in the joint. So the MRI shows clearly this osteochondral lesion, but it was not very visible in the plain X-rays. But eventually this patient, after 6 months of rehab, patient still had some sort of medial elbow pain, and you can see a little bit of arthritic change progression just after 6 months of simple elbow dislocation. So this is the actually end of our result. When we looked at all this osteochondral injury in simple elbow dislocation, stage 1, 2, just the bone contusion and edema is a very common in everywhere. But osteochondral fracture, loose body, I mean stage 3 and 4 injury, is very obvious in posterolateral capitellum. So when you suspect any patient with a severe elbow dislocation, simple, always this posterolateral capitellum is the place you have to have a very careful look at. So, advanced osteochondral lesion was more common in posterolateral capitellum. So, whenever you see a simple elbow dislocation, the pattern of soft tissue injury and pattern of OCD lesion, in a sense, they have some correlation. Still, I didn't find out whether it is really correlated with the post-traumatic OA or elbow instability or stiffness, but this is going to be studied more in the future. So if I summarize, osteochondral lesion of the elbow after dislocation is not very uncommon. It's very common if you take CT or MRI. And the mechanism, pattern of injury, is highly associated with the location of osteochondral lesion. Thank you very much.